Good evening and welcome to this exclusive session on the importance of continued medical education in protecting and restoring the health of the people and how we need to reimagine this invisible medicine at the time of COVID-19. I am Padmanabhan, CEO of Integrated Health and Wellbeing Council, India's premier institution for health awareness, advocacy, and behavior change. Continued medical education, or CME, is a term commonly used by doctors and healthcare practitioners. However, we, the common people, rarely discuss it or notice its impact in our daily lives. Actually, CME helps the doctors to trace the latest development in the world of diseases and epidemiology that in turn helps them to fine-tune the treatment for diseases. By identifying prevention methods, early diagnosis, or timely treatment of all diseases, CME plays a critical role in curing people. And the greatest testimony of it has been unfolding in front of us every single day during this pandemic. There has been constant chase of this virus, which has been throwing up several challenges in front of medical practitioners, researchers, every now and then. And it was for the CME to help these professionals continuously upgrade their knowledge about this fast changing and mutating virus that has unleashed unprecedented calamity on us. And when the very dynamic COVID situation demanded that doctors and researchers remain alert on the smallest twists and turns, CME ensured a seamless communication between them on the latest developments and the necessary modifications. And believe me, this has always been playing similar role for almost all other medical predicaments, be it today's commonplace conditions such as diabetes or hypertension, or more complicated problems of heart, stroke, or cancer. The pandemic has brought many changes in our lives and has reiterated the need for continuous learning for the benefit of humankind. And it is the time to reimagine CME during this global public health crisis in a way that help us protect, promote, and restore the health of all in the truest possible sense. To understand the colossal contribution CME has made towards the healthcare and how to leverage it further, we today have a panel of illustrious experts who are going to share their deep insight in conversation with my friend and co-host for this program, Faraz Jisan, from our partner in this initiative, OmniCuris, India's largest and most acclaimed digital CME platform. So over to you, Faraz, to introduce our esteemed panelists today and also take this conversation forward.
Thank you, Kamal. It's fantastic opening line. And truly, as you mentioned, CMEs have been an invisible medicine playing an invisible hand in the treatment of patients. And I would like to start this panel with heartfelt thanks to all the doctors who have worked through the second wave of COVID-19. And we have seen that medical fraternity have faced on-ground challenges, yet delivered the necessary healthcare for the patients. I, on behalf of OmniCuris, as well as ISWC Council, would like to provide a sincere condolences to all the doctors who have who have sacrificed their own lives at the end for this. Today, on our discussion today, as the pandemic continues, the importance of the accessible medical education to support clinicians who are managing critical patients in India is truly necessary. In this troubling time, when everyone is affected in one or other way, clinicians are stretched thin, or some even practicing in complete isolation, we need to strive to continue to provide them educational information for better healthcare management and as well as triaging of the latest symptoms which the COVID-19 has been throwing up. On a panel today, we have two heavyweights of healthcare sector. We have Dr. Padmanabha Shetty, who is a distinguished medical professional with his fame being recognized worldwide. Not only has been awarded a national professor by the prestigious Indian Medical Association College of General Practitioners, he has also been awarded Bharat Shiksha Ratan Award by the government. He has been a key resource person for more than 100 CME programs and as well as workshops, conferences for Indian doctors. Currently, Dr. Padmanabha serves as a president of Goa Medical Council, as well as professor and head of Department of Pharmacology, Goa Medical College. We welcome you, Dr. Padmanabha Shetty. Sir, you're on mute.
Thank you so much, Faraz. Nice to be in the platform.
Thank you, Doctor. And with us, we also have a professor and as well as chairpersons of psychotherapy program at the prestigious NIMHANS. Dr. Muralidharan Keshavan has etched his own name in terms of being internationally recognized all over Asia and the Western sphere, with his papers being 120 plus papers peer-reviewed, published everywhere. He has received Asian Young Psychiatrist Award, WFSB Award for Young Investigator, RSA Young Investigator Award, Young Investigator Award by ICMR and Government of India, and Samuel Garrison Award, and the list continues. We welcome you, Dr. Muralidharan.
Good evening, Faraz, and it's indeed an honor for me to be here on this panel, sharing the stage with someone as distinguished as Professor Rattaboli. So the honor is entirely mine.
Absolutely, Doctor. Absolutely. Today on our panel of Reimagining CME at the time of COVID-19 crisis, the COVID-19 has affected healthcare systems worldwide. That is something which is symbolic. But the disruption to the hospital routine, for which it was earlier, we had the continued medical education for healthcare professionals alike, the upskilling and reskilling has become necessary to stay on top. As we are discussing, there is a Delta Plus variant occurring, and the COVID-19 is presenting itself in the new forms of in different forms of symptoms for the patient. It's imperative for a healthcare public policy thinkers as well as to mitigate these new symptoms to provide effective healthcare. And to Dr. Padmanabh, this is my first question to you. You have been forefront in activating training and teaching and research in order to fill gaps through practice of skill for the healthcare professionals in Goa. In India's emerging healthcare sector, there is a strong need for multi-stakeholder engagement to promote technology of a CME at the grassroots level. What are your thoughts on the role played by future CMEs in bringing the change in Indian healthcare delivery, Doctor?
Yes, in fact, in Goa, we have already started online CME platforms much before COVID arrived. This is for more audience and better equipment. In fact, we have been doing online CMEs across the nation almost 5 to 6 years back. Now, because of COVID, there are more chances of online CMEs. Now, to educate our doctors, especially elderly practitioners, the thing with medicine is we have to be updated every day and every time for the patients. So we have special sessions for elderly physicians. We try to educate them, plus young doctors, the new pass outs. We have special sessions, we have CMEs for new doctors, new entrants with new technologies and online CMEs. And we hope to build on this with more technology, more advances, so that people become interested in knowing more things. The thing is, people hardly update themselves once they become the doctors. Once they pass, there is hardly time to read. So this CME platform is really invisible medicine, as you said. And we really try hard at Goa to update our young doctors, as well as the practitioners who are very busy with online CMEs, as well as when the time permits, we have offline CMEs every month and every week sometimes. state level CMEs as well as branch level CMEs.
Oh wow! You mentioned the very right aspect, doctor. Like it's imperative for us to train and upskill the elderly physicians who might be having a very high volume of practice occurring right now in whatever domain they are doing it. Maybe it clinical practice, or maybe it might be happening at a hospital. That is very true what you said, doctor. And we at Omnicurious, we have seen that when we launched a Niti Aayog program for 112 different districts in India, we have seen a age group of 45 to 56 years old doctors who are on
Yes.
the verge of superannuation engaging into the content. And we have seen the young doctors who joined right after the college for the PhD level training. And we have also seen these two groups performing really well. And the rest middle sector, the age group between 31 to 40 years old, those are the doctors who are self-updating themselves by various measures, which I definitely undertake, doctor.
Correct.
Coming to Dr. Muralidharan, you have been a part of learning, and you know how the functionality works for the doctors in terms of learning via their brains. I have one question, doctor, for you. The professional healthcare bodies have suggested using these recent practice-based learning and improvement for CMEs. Okay, consequently, newer CME methods are being designed to encompass the concept of practice-based learning. What are the new methodologies that we can include in CMEs to enhance the better care from bench to bedside, Dr. Muralidharan?
Wonderful. I think that's a wonderful question for us. So just to give you a brief background to what has been happening at Enhance. So the online or virtual CMEs and educational programs have been here for almost 10 years now. And it's just that COVID has opened up our eyes to the infinite possibilities that virtual learning holds. So we had what was called as the Virtual Knowledge Network at Enhance, through which we were conducting the training programs. This is again bedside skill-based training programs for doctors in remote areas. So Enhance was training doctors in say Himachal Pradesh and Uttarakhand, Bihar, Rajasthan. So across the country, we were having training programs in the area of mental health and to some extent in neurosciences. So this was converted into what is now referred to as a Enhance Digital Academy on the recommendation of the central government. So we already had the system where it was like a digital university which was running diploma courses, certificate courses for doctors who are working in the peripheral health centers, so that we could train them in identifying common mental health problems, substance use and addiction, problems with children, so that they can get some immediate psychological and psychiatric treatment before they reach the higher centers or specialized centers for treatment. So that was the objective, and to also familiarize doctors who are not well trained in the area of mental health and neurosciences in these areas. So we had certificate courses and all that was running. Now enter COVID, and suddenly we had to stop all forms of physical in-person learning that was going on in Enhance and also outside, like Professor Athapuri mentioned. But the learning cannot stop, and learning had to increase, especially in the times of COVID, because COVID by itself being such a dynamic situation, the virus is dynamic in itself, it's changing, it's mutating, new variants are coming, and we had to keep ourselves abreast with the changes that COVID is bringing about. And like you said, this also involved a lot of clinical bedside learning that doctors had to learn, but without having the benefit of actually being at the bedside. Because this was not a situation where you could actually go into the COVID ward and examine a COVID patient and learn. So there had to be a lot of vicarious distance learning that had to happen during this crisis, and this is where the virtual CMEs came in very handy. And Enhance started opening out. I mean, what I'm sharing is my experience. So finally, we could have people, say, experts in pulmonology, experts in, intensive care medicine. So we could connect with all these people and get inputs from them through CMEs that were conducted, how to identify COVID, what are the medications that can be used. Of course, these are things that have been changing over time, and CMEs are the only ways, and virtual symposia and seminars are the only way with which doctors could keep abreast, especially since the whole volume of research was being put out, and we have to sift the sand from the grain and take the grain that is necessary for managing patients. So I think virtual CMEs opened out our doors to a lot of other specialties to be able to assimilate what other experts have learned about. So including virologists, including pulmonologists, including the microbiologists who form integral part of the infection control committees. Infection control practices in hospitals changed, and that change had to be incorporated in the daily care of our patients. And so the only way to make sure that it reaches all cadres of staff was through CMEs, was through online platforms. It also gave us the opportunity to open ourselves and give our expertise to the healthcare workers working with COVID. Now I'm talking about the mental health needs of the staff.
Correct, doctor.
And doctors who are working in the COVID care centers, the family members of people who are affected by COVID. Now, the mental health requirement of the country actually shot up during the COVID pandemic, and it's being referred to as the hidden pandemic.
Absolutely.
And hidden pandemic of mental health. So the one way in which we could provide our expertise to the rest of the country was to conduct CMEs on psychological first aid, how to handle stress, how can doctors and healthcare professionals take care of themselves, the importance of self-care during this pandemic, the importance of one's own mental health care, to address problems of bereavement and grief that the healthcare workers were facing, as well as the general public. So this became a two-way street for us. The virtual to gain expertise from other doctors, other healthcare professionals in areas where we did not have the expertise, and to open out our expertise to other healthcare professionals so that they could make use of what NIMHANS had to offer in these difficult times. So I think that's a fairly long opening remark.
No, doctor, you actually highlighted one of the two critical points. One was leveraging the virtual network, which is there. And the second is cross-functional partnership between different specialities, like, bringing the equity. Else earlier, we had to go through a lot of these articles being published, then connect with them, learn if possible. I think NIMHANS has done that wonderful job of opening all the speciality. And one thing which you mentioned, a doctor, which is also playing a very pivotal role, the next India, I think we are still we don't have that many specialists in identifying mental health issues. And you said that is an invisible pandemic. I'll definitely come to you, doctor, on that. I have just noted it down. And coming to Dr. Padmanabh, and I think the last question where we discussed that we have seen an acceleration of digital CMEs programs that are happening, and these are being mandated by a lot of medical councils and a lot of these elderly healthcare professionals who are discovering shortcomings in their digital capabilities. As you mentioned, as we adjust to the new normal, doctor, regardless of specialty, and medicine as a field will always keep evolving and changing. And how do we go about in addressing concerns to these healthcare professionals who are facing digital challenges?
In fact, the biggest challenge is, as you said, digital challenges. What we can do is we can invite a small group for open session. Instead of having a big group, large group, people are facing problems of digital. A lot of people have these problems. In the because of low connectivity, bad connectivity. What I would say is we can have a small group programs, because we have tried these small group programs for pharmacy professionals. In fact, every 3 months we conduct such programs, continued pharmacy education programs, CPEs, for pharmacy professionals, where we invite around 100 pharmacy professionals in a hall of around 500 seaters. Correct. Different modalities in pharmacy practice. So same thing we can do for medical professionals. Invite certain groups. Say if you want to have some programs for elderly professionals, we can have some good, nice CMEs only on invitation, say 55 above or 60 above. That can be one more because of connectivity issues.
Correct, doctor.
Can be done.
I have seen that one of the technologies which we leveraged was that just one tap join the link, like how the Zoom has come into play. And we have seen we have seen the doctors who are working, a lot of these, even we do it, doctors who are above 60 years old, when they were registered, the font level changes. So we have designed these kind of small, simple features for doctors to actually address the issues. So we are leveraging technology. And I think I'll bring in Dr. Muralidharan as well here on this question, Doctor, what are the key features that a future digital CME should be having in their design of learning? Because as Dr. Padmanabhan mentioned, that there are challenges in having the dissipation of because there is no equity in digital capabilities right now. How do we address this concern by leveraging technology here?
So I don't know if I can answer on the technical aspects of that, because we have also done a lot of trial and error before we zeroed in on the online platforms that finally came in handy. And of course, once COVID came in, there were a lot of security issues that were highlighted about the various digital platforms that are there. So what I would say is that with the in terms of, like sir mentioned, the network connectivity and digital connectivity are issues that will be there. And however, now with a lot of especially the education sector, now you find that all the schools and colleges are having the classes online. There is no physical classes anymore. So I think in general there has been a move towards digital platforms for learning, and that has helped enhance. People have gone in for more. I don't know whether it's affordable or not, but they've gone in for better connections, better gadgets that can help them connect to these classes. It's more out of what was probably considered luxury earlier is now more of a necessity. And you can see that even in the government institutions, the learning has shifted to the online classes. So I think some of these issues the government will address. And
absolutely.
And they will have to address to ensure that we don't know when this pandemic is going to end. But then the learning has to go on, and not only for students, but even for the general public. So I think there's a lot of effort from the government side itself to ensure that the everybody can become digitally connected to the various forms of learning. But what I would also foresee is that this digital there was always a hybrid kind of model in medical education that was going on even before COVID. So in some CMEs we would have international speakers who would join in via an online platform, and the rest of the participants would be there in person and live. And I think even once the pandemic settles down, apart from these online CMEs that continue, we are also going to continue to see a lot of hybrid CMEs that will help educate professionals. Particularly, this would be a way in which you can bring about experts from the international arenas to come and talk to our own doctors and health professionals. So going ahead, I think connectivity and other issues will be addressed to a great extent by the government, because we have to anticipate a third wave. We probably have to anticipate another pandemic in our lifetime. We don't know. We talk about the Spanish flu that happened in 1920, but life is a lot simpler than I assume than what it is now.
Absolutely.
And we have to assume that we may see another pandemic in our lifetime going ahead. So we have to prepare, and digital connectivity is the best way to ensure that.
Absolutely, doctor.
I
Absolutely.
would just like to add one thing.
Yes, doctor.
Now,
Yes, doctor.
what we can do, if for people who find it difficult to have individual connectivity, we can invite people in a hall and have one big screen where that live connectivity,
Live streaming that can happen. Yeah.
it's a good option.
It's a model solution, doctor. I'm just noting it down.
Wherever there is a low connectivity, all these people can join in one hall. It will be a good. In fact, it will be like online semi only.
Correct, doctor.
That will be a good option.
That's what I meant by the hybrid model of CME.
Hybrid model. Yeah.
Yes.
Sir is absolutely right. That's the point.
What we have seen, doctor, like on an online platform, we have seen 4x amount of number of searches that have happened on COVID-19 compared to last from March 2020 to March 2021, and we have seen nearly 2x amount of people who are enrolling in non-COVID resources. There is a kind of underlying wave of upskilling among doctors where they feel that the new challenges are being presented, and I think I'm actually coming to Dr. Padmanabhan for another question on this, where I want to ask you, doctor, we have the specialty treatment that is happening for patient and it is happening irrespective of whether we have COVID-19, because the specialty treatment is always there. How do we enable this specialty training effectively using digital CMEs, Dr. Padmanabhan?
In fact, same what we did in Goa Medical College.
Yeah.
We called all physicians and all the different specialty people in a hall
Yeah.
and discussed the modalities of treatment.
Okay.
Physicians who were treating COVID, they
Yeah.
discussed various modalities of treatment. What we did here was, physicians were too less to cater to a whole lot of COVID patients, thousands of COVID patients. So
Okay.
different specialties, people were posted. Like
Okay.
even paraclinical, preclinical people were posted.
Okay.
We found it difficult to handle certain COVID cases. So
Okay.
it was an open gathering where all specialists were called and the modalities were discussed. Same thing we
Okay.
can do online. In fact, we can online
Got
modality.
it.
Experts can be called on a common platform. So various specialties like main specialties would be general internal medicine, pulmonology, anesthesiology, surgery. So main specialists, if they are called on common platform, and each of them, if they discuss their modalities of treatment, then it would be a very good platform for others to understand. In fact, we had certain workshops in Goa also highlighting COVID treatment.
Absolutely, doctor.
We have already organized COVID management platforms where different
Yes.
immunologists, internal medicine experts, they discuss different modalities of treatment. So it has been done. So that becomes a virtual CME.
Absolutely, doctor. I've seen it was a weekly series which was activated by the Goa Medical Council, and as well as we had flyers coming around, all the doctors participating in.
Yes,
I have seen the flyers, doctor.
yes.
Dr. Muralidharan, I have this question, and my apologies because you come from NIMHANS and neurology and psychiatry, and I've kept these kind of little question in terms of so that you provide us a scientific way of learning, and that enables us to understand what we are looking at. See, Indian doctors, like, there are variations happening from the Indian doctors are practicing at Kanyakumari, Kashmir, from Bombay to Assam, Silchar. Okay, and they are catering to lakhs and millions of patients every day. What are your recommendations for the digital CME programs to bring inclusivity and build information equity for the doctors to streamline quality care?
Okay, now that is a very, very important question, and that is something that we are getting requests actually from a lot of patients. Now, being a premier neuropsychiatry institute, we were getting patients from across the country, and they would come here and access our services. Now, the situation is not possible. Different states have imposed various restrictions on movement. Bangalore is only now just opening out only in the last couple of weeks, and patients are finding it very difficult to access hospital services. And the expertise that NIMHANS has cannot be provided now in person to our patients for these very reasons. So there are a lot of patients who are reaching out to us for telemedicine-based consultation. Okay. Now, telemedicine-based consultation, while it is something that has been recommended by the NMC and some guidelines have been released, I'm not sure if all the doctors who are practicing are comfortable with it. Now, telemedicine is something that can be done for patients who understand how this works, and also to a great extent for patients who have already received first consultation and are now coming for follow-up. The government has also opened some portals like eSanjeevani, which will facilitate consultation. So what these CMEs will do is it will help us upskill doctors working in these areas through digital connectivity. And that is what NIMHANS was already doing earlier, especially in the area of addiction, in the area of epilepsy management. These are common problems that are seen in the world. So managing depression in the primary health centers. So like you said, we now cannot cater to these patients in person. And let me tell you, the outpatient crowds had dropped to almost 1/4 of what we would see on an average because of the lockdown and other things. So we did not have a choice but to share our expertise with doctors working with the periphery. So all departments had different kinds of CMEs going on. The neurology had CMEs on managing epilepsy, identifying multiple sclerosis, or caring for patients with Duchenne muscular dystrophy. The neurosurgery teams were collaborating with the doctors across the country, especially in the management of this recent problem that we are seeing, mucormycosis. As an intracranial extension and neurosurgical intervention is required. But there are so many districts and so many places where you do not have a neurosurgeon available. So again, the virtual CMEs and virtual CMEs which involved hands-on training, I mean skill-based training rather, I can't say hands-on, where there was a live telecast of surgeries being performed so that people in the surgeons can do that if they get some basic level of training and expertise. And of course, a lot of such upskilling has happened in the area of mental health, where there's an acute shortage. You know, from the time I was a student till now, we keep saying that there are 3,000 psychiatrists in the country. The rest of them have gone abroad. So we need to, and all the healthcare professionals we produce since then are serving elsewhere. So I think we need to the district mental health programs are a thing in the direction to improve the availability of mental health professionals in all the districts. And now the virtual CMEs have become our way of training the doctors in the periphery. So earlier there were some arrangements wherein they would come to your hospital 5 at a time or 6 at a time, get a degree or a diploma, and then go back and serve. Now we have gone on to the digital mode. We are training the DMHP doctors via telemedicine-based thing. So their skills, the interviewing skills, how to examine a patient, all these are being done virtually so that they will be able to cater to the patient. This also helps us to have a telemedicine-based consultation where a doctor at the other end can examine the patient with guidance from a more tertiary care center. So we are also confident that way that a doctor is examining the patient and we can...
absolutely. Yeah, that is accountable at least.
So that is a form of bedside digital learning that has started, and I think it will continue because as the peripheries like you were mentioning.
That's true, doctor. I think I'll ask Dr. Padmanabh the same question. Dr. Padmanabh, as I mentioned earlier, that there's a lot of doctors who are practicing the mucormycosis treatment. For example, would be a different in Jaipur, and it will be a little variant in Madurai, and the similar thing would be in Chennai, and something similar or little variation in treatment or the symptom that is presented across Assam, Silchar, or be it Himachal together. How do we bring all these doctors together on a similar platform to straighten the regimen in terms of treatment?
In fact, there is a standard regimen for mucormycosis. Wherever you get a case, right from Kashmir to Kanyakumari, the treatment for mucormycosis will not change much. The drug of choice is liposomal amphotericin B.
Correct, doctor.
Treat a patient, get the drug of choice. Only the biggest problem that we face now is there are more cases, more demand for the medicine, but less supply. And this is under control of center. So,
no, doctor. I just gave an anecdotal this thing. How do we build this kind of a streamline information so that all the doctors are on the similar page when they're treating a patient of a certain?
We can have a protocol. We can have a central protocol.
Yes,
which
doctor.
is by CDSCO, Central Drug Standard Control Organization.
CDSCO.
And once this protocol is laid down, this protocol is circulated to all the councils and all the doctors.
Okay.
It is circulated to all the medical colleges, all the councils, state councils.
Okay.
And they further can disseminate the information to their own practitioners.
Okay, doctor.
But as I said, the protocol is already laid down. There are drugs of first choice. If that is not available, what is to be done next? Posaconazole, isavuconazole. So these guidelines are already laid down by the center.
Correct, doctor.
Guidelines at the level of the state. Like for example, in Goa Medical College, we are having our own guidelines. How are we going to treat mucormycosis? So once the guidelines are formulated, then we can give the information to our members under our state.
Correct, doctor.
We can have a common platform at a national level where protocols are formed, standard operating procedures are being laid down for treatment of mucormycosis or mucormycosis complications, post-operative cases, how each case is to be handled. So these guidelines, if they are fixed by experts,
okay, doctor.
Mucormycosis is not dealt with one person.
It's a team effort, absolutely.
From eye, ENT to neurosurgeon to brain surgeon. So these are so many different specialists involved depending upon what stage of mucormycosis we are dealing with. So the guidelines change from stage to stage. So as you said, we can have a common platform, we can formulate common SOPs, and then through virtual CMEs, this information can be disseminated to all the states, and from each state, they can themselves disseminate it to their own members.
Correct, doctor. Doctor, as you mentioned, that all the formulations and guidelines are set by the panel of experts. I think there lies a little gap between the translation of these policies, because we did see rapid changing guidelines coming up during the COVID-19 and even the second wave. The amount of time it took to trickle down from the experts, like at least to medical council, and there are few medical councils and as well as state doctors.
That is the reason why the virtual platform is the best. So what I would suggest, if at the center, the panel of experts formulated the guidelines,
Yes,
through a virtual platform, they can definitely transmit the information to every state.
Yeah,
So if
that is.
say state modalities, like say council, experts in the council sit across a common virtual platform, then this information which is given by the central authorities can be disseminated to the state authorities, and from state authorities to their own members in the state. So immediately, suppose the new guideline comes today, the information can be disseminated the next day by virtual platform.
Absolutely.
So it is not difficult at all.
Absolutely, as you mentioned, right, Doctor. And I'll ask you another follow-up question. My apologies, Dr. Muralidharan.
Yeah.
I'm following up with Dr. Padmanabhan. How do we measure the impact of these CME at the patient level, at the PHC levels? How do we evaluate that?
How do we
evaluate the impact of the CME, which is bringing in terms of training for, let's say, COVID-19? How does it affect at the same time for the doctors and their practice?
Because once this, the problem is, like for example, mucormycosis. The doctors are not at all trained to treat a mucormycosis case, because they have never seen these cases earlier. So these common virtual platforms or virtual CMEs will definitely be a big guide for all these doctors who are now getting trained slowly but surely to treat mucormycosis. In fact, now in Goa Medical College, we almost have 20-25 cases of mucormycosis right now being handled by people who did not handle these cases earlier. We have never seen these cases earlier. But now, I can tell you, people are experts. So we have formulated our own guidelines. We have disseminated the knowledge to everybody through virtual platform, through online platform. So similar things can be done. So it is not difficult. Once the guidelines are formed, the treating doctors always arrive at a common platform, listen to experts, and then formulate, modify their own guidelines. Like for example, if liposomal amphotericin B is not available at that point of time, we cannot keep the patient untreated. What is the next line of treatment? Say posaconazole. So these guidelines are being formulated in such a manner that there are alternative treatments also offered. Okay. If liposomal amphotericin B is not available, we have conventional for the time being. Wherever the patient is safe and fine, we can use conventional amphotericin B. So there are certain guidelines, and information has been transmitted. Like for in Goa, everybody is familiar with the treatment guidelines.
Absolutely, doctor.
We are treating a mucormycosis case to virtual platform, to media. Everybody is familiar with these guidelines. So
absolutely. That is right, doctor, what you mentioned, that the guidelines that they will trickle down and that help. And you mentioned that mucormycosis, when before the pandemic, the doctors, all the doctors, only the specialist ENT were facing this issue, but now it has suddenly opened up. Even in the general practice, people are seeing these kind of cases. I would like to go to Dr. Muralidharan on this one question. Doctor, we have seen that informed educators like you have always have an optimal mode of learning, and you know what to set as a context, and you also take into account a learner, what are the needs of the learner. A digital CME offers a flexibility and responsiveness to the learner's need. What are the new guidelines and what are the new forms of education that a leading healthcare CME delivery or leading CME providers can incorporate in training to drive better outcomes in Indian healthcare?
Yeah, so some of the things that are already being done, and,
yes, doctor,
and which can be scaled up to all CMEs. Again, it will depend on the group of people for whom the CME is being addressed. Like for example, let's say if I'm conducting a CME for psychiatry postgraduates, what I would do is that we would do a pre and a post questionnaire. So before the CME, we would distribute. Now it's easily doable. You just send something like say on SurveyMonkey or something like that. They prepare these Google forms, right? So you send a list of questions which you expect the postgraduates to answer, and you will get back their responses. you have certain learning objectives for your CME. And what is it that the CME wishes to convey to this target group of people that we do? Conduct the CME and send the post questionnaire. So one way in which we ensure that the post questionnaire is answered is that the certificate link is there at the end of the post questionnaire. So the minute they are able to submit the post CME questionnaire, they are able to access the certificate. There's some kind of incentive for filling up the post questionnaire. And that is what people who are conducting the CME can use to see how far the learning objective has been met. Now, whether the pre and post, whether there's a difference in terms of the performance between the pre and post questionnaires. Now, this was something that was being done even with in-person CMEs, but with online CMEs, it's become a lot easier. And you can get their responses as soon as they hit the submit button. And a lot of schools and colleges are using that mechanism of online platforms for conducting their tests also these days. So those are something that can be used going forward. But again, like I said, it depends on the group of people. And like Professor Rattaboli was talking about, if you're talking to more senior people and more experienced practitioners, then this modality is probably not going to work.
Absolutely.
I would think that a program like what you've done now, a panel discussion, which has a more interactive kind of session where the practitioners can pose questions, because just to take forward the professor's answer to the previous question, right? The guidelines can all be circulated from a central place and it will come down. But in the actual clinic and by the bedside, a doctor may face a lot of challenges which the guideline may not. So it will just give a common minimum thing that everybody has to do. But there will always be some exceptions to it. And in life-saving condition, when you have to do some life-saving choices, the doctors will have to act on their own discretion. So a more interactive panel discussion kind of a program where the people can ask more questions. They can share their own experiences in terms of what kind of challenges they are facing. So I think some of these things can be done to ensure that the learning objective of the CME is met going forward. Does it answer?
Correct, doctor. That was actually a wonderful thing what you mentioned. We do that with our Omnicurious platform. We kept questions to gauge whether how much optimum information they have gained, and we also added something called gamification. And we now provide like the modules, after one modules, each 5 questions are there to gauge whether they are learning, how many attempts are being done by the doctors. We map it out and we concurrent it with the objectives and the learning needs. And the questions are formulated in a very conceptual form unless you have a very critical understanding of the subject being transpired in the CME. A doctor or a specialist would have a hard time answering that question because that requires conceptual understanding. Coming to Professor Rattaboli, I wanted to ask you, and Dr. Muralidharan earlier mentioned, that there is a lot of cross-functional CME development that is happening, and we have not seen it before. And you, being a very precursor for a lot of these 100+ CMEs, Doctor, how do you see this role will playing out in the post-COVID-19 times? A cross-functional CME coming into play together between a neurology, let's say internal medicine, pulmonology, internal medicine, ENT, and then ENT and a neurologist. There are a lot of different combinations coming up between specialities. How do we empower this cross-functional assignment between different organizations and as well as associations to bring them together on a common platform?
What I would say is COVID-19 is a multi-specialty topic. So the need of the hour is really to get people from different specialties. So whenever we are having any platform to discuss COVID-19, we cannot have a single specialty. There has to be at least 5 to 6 practitioners. Minimum would be an internal medicine, a pulmonologist, anesthesiologist, surgeon, plus intensivist. So these are the basic people. In addition, there could be a community medicine person, psychiatrist, COVID psychosis and post-operative complications. In fact, we see a lot of psychiatric complications, as Professor Muralidharan has said. So a psychiatrist is also a must in these platforms. So I would suggest that these multi-specialty platforms would really do a thing of good. And that is the need of the hour these days. We cannot have a single member platform for COVID. Similarly for mucormycosis, we should have a multi-specialty platform so that at the end of discussion, we can have a panel which really answers all types of questions which are put to them. We can have a short half an hour open discussion followed by a panel discussion. In fact, that is the. In fact, we most of the times when we have sessions in Goa, we do have say 5-6 people presenting their views. Say multi-specialty people. Even recently we had CME on COVID. All aspects of COVID. Different specialists they projected their views half an hour time. Then we had a panel discussion where all the participants were allowed to ask different questions. So all their views can be answered in one common platform. That is the need of our input.
Correct, doctor. And as you mentioned, right, that the COVID-19 actually opened Pandora's box, and now we have seen a partnership between our cardiology, internal medicine, hepatology, and as well as other multiple different specialities coming together and helping and transpiring this knowledge carnival for the doctors to help assist them identify markers right now. And I think that has changed the complete Indian healthcare. Now,
what I would say is not only doctors.
Yes.
In fact, now the need of the hour is to educate pharmacists and also the nurses.
Wow.
Because they are also frontline warriors who are dealing with COVID patients. They should also be updated. In fact, as I said earlier, we are having sessions for pharmacists. So nurses also have to be educated.
That's true, doctor. That's true, doctor.
Also a part of COVID war.
Yeah, that is totally true, doctor. The pharmacists, the continued nursing education, as you mentioned, is very pivotal, because these are the people, like once the doctor is like, the presence of doctor is cure. After the medicine, the administration of medicine, the
general practitioners, because there are a lot of general practitioners who do not know what to prescribe at what level.
Correct, doctor.
Steroids are being prescribed right in the beginning, so that can further aggravate. Mucormycosis also can be aggravated by the use of steroid. So these finer things should be taught on a common platform where general practitioners also can be part of it.
Correct, doctor.
Yes.
That is very true, doctor. Like, addressing, a fast delivery, as you mentioned in your previous question, the transpiring of the guidelines and everything continuously coming down, trickling down, not only to doctors, but it's imperative to be transferred to the our nurses and as well as pharmacists and all the frontline warriors who are there facing these challenges. And I think I'll take one question, the last question for Dr. Muralidharan. Again, Doctor, this is something which I wanted to see. We have seen the CMEs continue to drive its effort, and there was a lot of CMEs being done at multiple different platforms coming in. The doctors, one thing which we have seen, that the doctors are stretched thin when they are working. They have these patients, the amount of patients and the timings of change for the doctors when they're learning, and there are few doctors who are at the PhD level who are utilizing their phones to learn. Apart from doing this, getting their CME credits and save time and improve the performance of their essential life-saving work, what are the key things what you envisage or you feel that is needed in a digital CME today? I mean, for an example, for me, a CME would definitely have like a gamification, the kind of live surgeries, or maybe the live treatment of a patient. On those lines, doctor, what do you think is the key ingredient which would revolutionize this future CME? Because as we know, the digital CMEs are not going to go anyway. They're going to be the next future of the healthcare industry.
I think if I can put it in one sentence, it should be the felt need of the doctors.
Okay.
Rather than conduct, I mean, we all have our areas of expertise.
Yes,
we
doctor.
Have certain skills that we bring to the table, but at the same time, sometimes the CMEs especially have this tendency to go over the head of doctors for attendance. So it has to be in these times when the amount of time that doctors have, apart from the clinical work, to attend CMEs and to learn new information, barring things like guidelines which Dr. Rathapoli mentioned, all other CMEs that we're conducting should be in keeping with the felt need. What is it as a practitioner that I want to learn? And the institutions like NIMHANS or other educational institutions, medical councils should try and match the requirement of the doctor with the expertise that can be provided through the CMEs. So I think future CMEs in the time of COVID are going to be driven by the felt need of the doctors who are going to be attending. And that will stay for some time to come.
That is a very wonderful way of putting it, Dr. Muralidharan. That is the felt need for the doctors. It has to be driven by the interest of the doctor, and we have seen that when we use machine learning and when we provide content. Let's say there is we have a pulmonologist. When we show that anything which is related to COVID or pulmonary medicines and everything, they get the nudges and their engagement is really high when we have this. I think that is one of the great use cases. And Dr. Professor Rathaboli, I would like to come to you as we are coming to our end. I would like to have a closing statement on you, Doctor. What is the prominence of digital CMEs post COVID-19?
Yes, digital CMEs are here to stay, because I don't think we should be right now going back to online CMEs, at least for the next year, because COVID is here to stay. We have to live with COVID. So only platform available is digital CMEs. And every doctor has to update oneself because guidelines go on changing. We cannot stay in the past. We have to update ourselves regularly for guidelines. Today there is ivermectin, tomorrow ivermectin is out. Today we are having different guidelines from the center. No hydroxychloroquine. There was a time when everybody was taking hydroxychloroquine. But now no hydroxychloroquine, no doxycycline, no ivermectin. So people have been using these drugs right, left and center. So every day the practitioners have to update themselves. And the only way to update are the virtual CMEs. And that is the need of the hour today.
Absolutely, doctor. On the similar lines, what we have seen that, we ran a program with Niti Aayog for 112 aspirational districts to train the government doctors and as well as the general practitioners there in terms of the latest regimen that was happening. And we saw nearly 50,000 plus HCPs joining across catering to 76% of population of India. And the guidelines keep changing and we had to keep updating ourselves and be on top of it so that it can be done. But thanks to the active leadership of Amitabh Kant ji, we were able to transpire that to a very easy form of learning for the people. Coming to Dr. Muralidharan, I would want a closing statement on you, doctor, and how would new forms of modalities are going to affect the learner's brain or as well as learning for the doctors in the future. Dr. Muralidharan, a statement?
So what I would like to say as my closing remark is that COVID has made doctors who are ordinary individuals handle extraordinary amounts of stress. So we are ordinary individuals handling an extraordinary situation. And like Dr. Rathaboli aptly mentioned, the situation is so extraordinary that the requirements of the doctor and the knowledge has to be updated on a daily basis. So I think in terms of going ahead, the CMEs are the only ways in which doctors can keep themselves updated in this extraordinary situation that we are in now. Nobody trained us to handle it. This is something we are learning on each day, and this is something that we are learning with each new patient that we see and with each new guideline that comes up. So CME is the only way. Digital CMEs are the only way in which we can upskill our knowledge, we can update ourselves, and make sure that we can save lives, which is what it translates to finally.
Absolutely.
And Sir aptly mentioned that digital CMEs are here to stay, and there's no hiding from that fact. And the more we learn to harness technology and whatever else it brings. Right now, we only do something like sharing slides and those kind of things. But I'm sure there's a lot more that technology has to offer. I'm sure there is going to be a day when we will have something like a virtual reality kind of CMEs, and 3D technology is going to transform CMEs to a great extent. I really don't know going at how, but digital CMEs are here to stay, and the faster we embrace technology and understand the enormity of it and how best it can be harnessed for medical education, I think that's one way to ensure that the doctors will stay trained and updated. Thank you.
Precisely, Dr. Muralidharan, as you say that we are aware that there are tremendous advances that is happening in technology. As you mentioned, Professor Rathaboli mentioned that we need the technology needs to be integrated, technology needs to be leveraged to cater to all the segments of doctor, not only the young doctors, but also the elderly doctors who are treating patients. And with the medical field like continuously changing as Professor Rathaboli mentioned, that we are seeing a continuous change in guidelines coming coming up, and there is a new modalities of treatment regimen. And Professor Muralidharan, where you mentioned that, the cross-functional partnership between opening up our own internal researchers to bring that equity and mobilizing and as well as catapulting the research for one subject by coordinating, that keeps that makes us very much dependent on the CMEs and working together with multiple different associations and departments to create information symmetry for the doctors, which helps them in the ultimate healthcare delivery. And I think with this, Doctor, I would like to also thank ISW Council for helping and coordinating this event. And with the second wave fading, every day we acknowledge the role of health workers that have played a critical role throughout the COVID-19 response, and they still continue to serve at the front. And many doctors who have provided the management and as well as treatment for the disease which they little understood, while others have accelerated and helped us enabled we have received vaccine from it. And as well as we see doctors leading the front in helping the vaccination drive, and as well as treating the comorbidities which are being still the COVID-19 is evolving. As Dr. Muralidharan mentioned, it's a very dynamic part of the COVID-19. We are seeing different variants coming into play. It's imperative for all the doctors to be abreast with the latest, and as well as a responsibility on the experts of creating better CMEs, and as well as to provide, as Dr. Muralidharan mentioned, a felt need of doctors. And I think with that, I would like to conclude, and I would like to thank all the doctors and dignitaries who have joined in for this event. Thank you very much. From Omnicurious, signing off, Faraz Zishan.
Thank you.